Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. We are live on the March 11th, 2016 edition of Finally Friday, and I want to thank you for choosing to spend your time with us here on Finally Friday. We have a great show for you this week. We'll be talking about how skilled nursing facilities are about to be attacked by the RACs. And we're also going to be talking about the rise of coding validation reviews, and Sharon Easterling is going to share with us a couple of denials and how she won or got those denials overturned. So today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. Also by Recovery Analytics, which is Sharon Easterling's company. She does auditing and education, writes articles for AHIMA, and as you'll see today, she's committed to your success. Finally Friday is also sponsored by MedLinks Cost Containment, the makers of Healthcare Audit Tracker. You can visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. Another sponsor is Aerolib Healthcare Solutions, a patient-centered, total quality management consulting firm. It's run by Dr. Deepak Pahuja. He's the maker of the Physician Advisor's Guide DVD, which is available on CD and also on demand. And now he has a new learning management system, which is completely designed to be customized, trackable, and effective. And you can find that at his site, aerolib.com. And then finally, we have the Council for Certification of Medical Auditors, the CCMA. They are the creators of the widely used Certified Medical Audit Specialist certification, also known as CMS. And you can learn more and earn more. Go visit their site at certifiedmedicalauditor.com. Okay, so today we're talking about a new report just published by CMS, along with a database, that is about the issues they see in claims that are billed by SNFs across the nation and how they are now sicking the racks on these SNFs. Now, we're also going to talk about the rise of coding validation reviews, and we're going to look at some of the comments that were made this week on the Rack Relief Google group. And then Sharon Easterling is going to show you two examples of coding validation denials and how she got them overturned. So, I do have Sharon with us today, my loyal and faithful co-host. She's an auditor, speaker, writer, and an appeal writer. My other co-host, Bill Mom, who's a practicing clinician, speaker, writer, and a certified medical auditor, is not able to join us today. I think he's on a plane. And I don't think Chris is going to be joining us today, as I know that they are both dealing with work things. You know, those things where they make money. Okay.
And Bill said he'd be on late, I think, possibly.
Oh, okay. Bill actually may be able to join us. That's great. Okay. Anyway, I want to make sure before we get started that the opinions shared on this show are those of the panelists, not necessarily representative of their employers. My opinions are certainly my own and no one else's, especially not those of our sponsors. So before we get started, let me see if I can bring up the website because I wanted to let everyone see. Let me see if I can get over to that. Yep, here we go. If you are new to the show or if you have forgotten how to run the control room, that's the tabs, the green tabs at the top of your screen when you're watching the show. You can always go to any page on the site, scroll down to this one with the green buttons on it, and it will take you to a page that will show you all about how to access the audio differently, or how to get to the you want to open the chat box. That's that second button from the left. If you're new, make sure you open the chat box. We have it. It's an active public chat box. I just ask everybody to please remember there's different people in there. Please be professional in your comments. But you can ask questions or make comments anytime during the show. This is a discussion, not a lecture. And we will try to handle your questions and comments as we go along. I also want to remind you that while the video of the show is being recorded and the audio, the chat room is not recorded, so that's not anything that could be discoverable or anything like that. There is a way for you to zoom in on the screen if I'm not zoomed in enough, and you might want to pay attention on this one because there are a couple of slides that have some small text because there was so much to put up. There's also a participants list so you can see who's here or talk to somebody. You can chat to them individually or to everybody at once. Let's see, quit clicking on the box, Ernie. Okay, and other options. No, I'm not going to give you control of the room. Okay, so with that, I think I can go back to, I want to remind everybody I really like our theme song. It's under fun stuff on our main menu, so I can't play it during the show because the audio doesn't come through. But anyway, you want to go watch it if you haven't seen it before and share it with your revenue cycle or revenue integrity team. They'll have a good time. Okay, let me get back to the show. Get it to come up here. Here we go. Okay, so last week we talked about, it was like our second or third time we were talking about just how the shape of the revenue cycle has been changing. And we talked last week, we gave some keys on how do you prepare for that? How do you make sure that you're getting ready for that? Because lots of things are changing. Even, Medicaid is probably at the top of the list, whether you know it or not. We talked about that last week. This week, as I said, we're talking about these SNF RUG reviews. That's the resource utilization groups that are used for determining the billing levels for the SNF claims, which are Part A claims, but sometimes they wind up being Part B. And then we're also going to talk about coding validation reviews, which seem to be more prevalent lately, and especially were identified in an OIG report recently, and there was a lot of talk about it on the Rack Relief Google group, so we're going to look at some of those comments. Before we get into that, let me just go to a few news items. One thing that came out this week was the TQRS, these value modifier results, and that was published. Now you can click on the link in the deck. It will let you get to the memo that was published by CMS about this. And it's basically, it's their report how there were some people who got the increased payment. There were some who didn't. Most did not. So you can go look at that and see what's going on. And you may really want to pay attention to that, especially because if you look closely at it, you find out that it is being phased in, which is always a good idea. But by 2017, it's going to apply to all physicians who are solo practitioners and those in groups based on their performance from 2015. And then in 2018, it's going to start applying to physicians, nurse practitioners, physician assistants, basically everybody else.
Right, and this is a huge part of MACRA, Ernie, that we've been talking about in that merit-based incentive program. All of these things are going to join together, and it's going to really impact the amounts that we're going to be paid for our Part B services. So this is a great report to look at for your, physicians. I'm sure someone's already looking at it at your hospital and have concerns or not. But that's why it's so important that we're putting our documentation efforts into place on the ambulatory side.
Yeah. So, okay, so that's where you can go get the report in that link in there. And then this is the page that was published by CMS on the SNF data. So you can go find that. I've got the link on the screen there, and also so you can click on that or the original article link. That'll take you to that page or to the fact sheets. But Sharon, you got a chance to look at there were a bunch of links on that page. I didn't get a chance to look at them, but what were in all those links? I suppose I could bring that up.
Yeah, basically it was breaking down what's going on with our billing for rugs. It's increased drastically over the past few years. And it's based on your activities of daily living. That's kind of what your rug score is based off of, and those activities have a point system associated with them. So if you need assistance, getting dressed in the morning, that gets a point and a weight. If you need assistance with functional activities related to in the kitchen, that has a weight. And those things are weighted out, and it's, I don't know, probably about 12 to 15 areas of ADLs that it looks at. And the higher the activities of daily living points you get is the higher it affects your rug score. So you get a higher rug score. And many of these, it appears that we have ultra high risk scores. So that means these patients need more training and assistance than others. And it appears that we have a large volume of CIF patients that are in the ultra high level. There's levels, there's low level, there's medium level, there's high, and then there's ultra high. Lots of these patients are falling into ultra high. So we have a small percentage that's in medium. So let's just say I saw one example for one particular, I want to think it was related to rehab. In the medium category, they had about 870 days that were submitted for that particular rug criteria. But then for the ultra high, there were 8 million days that were associated with that. So are we overcharging that? And I think that's where CMS is going. Looking at the spreadsheets, if you get a chance, go out there and look at them. Visibly, you can see that we don't have some of the lower scores. Everything's ultra high. Well, could that be because we get more hip and knees replaced than we did a long time ago? People are more conscious about doing that type of surgery than they were before. That's requiring a SNF visit. That's requiring the rehab. Is that a possibility? Is it a possibility that we're just so busy in our daily life we're putting more people in the SNF? I don't know the correlation there. But what are the reasons behind that? And I think CMS, like Ernie was saying, is trying to say, look, this looks improper. It looks like you're overcharging your minutes of time associated with activities of daily living and pushing more of these patients into a higher category.
Yeah, I think that in particular they were saying there were a lot of articles that were in the news on the web this week about this. There was a pretty in-depth report, I guess, on the Wall Street Journal. I couldn't get to it because I don't have a subscription. I guess I'm going to have to go ahead and do that. But they were saying that the thing that CMS was seeing was that there were an awful lot of RU assessments between 720 and 730 minutes. In other words, just enough to qualify for the 25% higher RU payment. So, come on. That does look pretty suspicious. A lot of people billing 730 minutes, they're saying, basically, you guys are gaming us. We know it. Cut it out, or we're going to come after you. So I think it's, let's see. Oh, yeah, Stephanie's saying, is Part B modifiers a big deal? Wonder how many knew about it and if medical staff has been informed. It's a good question. And Dr. Johar, Maria Johar, saying that with the CJR bundle, hips and knees will be under scrutiny too. Yeah. Many hospitals are being creative in that sending to rehab. There's hotels with outpatient rehab. Okay. So anyway, it may be a bigger deal than you think. Certainly CMS thinks it's a big deal because they're saying basically they're going to, they want the industry to, police itself. We're trying to quit trying to get the 25% more, because, and on some of those articles that I read that were out on the web, I read comments. Now, it's just anecdotal, but I can see how it could happen. There were some therapists who were saying that they felt a lot of pressure from their administration to get to the 720 minutes a week. So I don't know how that happens. I don't know what they do exactly to make that kind of pressure, because obviously that's not a good thing. So
well,
anyway,
Ernie, just documentation, and wish Bill was on here already because he loves to talk about this kind of stuff. But just documentation in your EHR related to those activities of daily living can be kind of trying. Because you need to be really descriptive about the functionality of the patient and how what therapy you are doing is impacting them. And we don't have that freedom necessarily in that EHR to document that. And I don't even think we were even doing that very well on paper. That's always a challenge when it comes to therapies and when it comes to documentation and when it comes to justifying your time involvement. Clearly identifying what the goals are and clearly addressing how what you did impacted that goal, and then the end result of the goal. And laying those things out clearly is really been difficult for providers.
Oh, and I see, Stephanie, yeah, you're commenting. I thought you were joking when you said hotels without patient rehab. No, you're serious about that. Yeah, we've talked about that before. This whole problem of outpatient services that you really can't afford to do in the hospital. So yeah, you are doing it with a large hotel chain to provide outpatient services for routine CJR patients, high amenities and low cost. I think that's a great idea. And it may be a big help. At any rate, here was one of those articles that was about how the ultra-high therapy is prompting an investigation. So here's what I was just saying. More than 20% of the facilities provided ultra-high and very high within 10 minutes of the minimum threshold. The numbers involved, the dollars involved are not small. So they're paying attention, and they're going to pay more close attention. So it behooves the hospitals to start paying more attention to what you're doing there. And certainly, they haven't exactly said somebody's gaming the system, but effectively that's probably what's happening. So the other thing, so we are going to talk about some more of that a little bit. But like I said, on this week, we're going to talk about how basically CMS basically says, hey, something stinks, and so they're going to sic their attack dogs, because they not only are going to, they're not just threatening to come after you. They basically are turning this over to the racks. That's what they are saying. So, it's like, there's lots of different things that, may come up in your life that stink, like, the can of sardines that you wait up, when you're a kid, you wait up until midnight for your dad to come home from the late shift, and then he sits down with a can of sardines and crackers to watch TV, and you die because they stink. Or maybe your roommate left, a dinner from last week in the refrigerator, or you got old sneakers, or maybe you've met someone who likes the zombie smell, so they bought that Essence of Manhattan. Lots of things can stink. So the question is, do your rugs stink? So you want to take care and go look at it. Now, how can you do that? Well, let's see. Now, somebody's saying, Viewer 92 comment, for profit SNFs are pushing for RU and RV rug scores, not only for higher reimbursements, but for quicker patient turnover. These corporations hold the therapist to standards of delivery to provide no more than 2 to 3 minutes beyond the rug limits. I'm not sure I understand that. Why would they hold them to provide no more than 2 or 3 minutes?
Ernie, It goes back to what you were saying earlier, where it requires the 720 minutes and you see a lot of 730s. Well, they're going just over that amount of time to meet that particular rug. So I think that's what Viewer 92 is saying, that, you know, once you get there, you only need to do 2 or 3 more minutes and you can bill it.
Oh, okay.
Yeah.
Yeah, and I can see how they would want to do that, but that's not going to fly. I'm sure it's not. I would not want to be the one with that kind of a standard and get called on the carpet by CMS and the OIG and the Department of Justice.
Absolutely inappropriate.
Yeah, and there are some, they mentioned here in the article about rehab care to large therapy companies settled $125 million whistleblower suit. And they were not the only ones who had to settle. There were several skilled nursing facilities that had to settle as well. Yeah, if the trend is identified, it could be gaming the system. And Dr. Field saying that's the same standard for E&M billing. Yeah, we're going to get to that. Dr. Field, very good. And I'm glad you're on today because I've got a comment by you a little later we're going to look at from Rack Relief. And there's some very good stuff I want to talk about. And it does tie into the E&M billing because basically this stuff is kind of subjective. I mean, there's a line drawn at 720 minutes, but you know, I think it's a subjective judgment as to whether or not they really needed that much or more or less. And there's a problem with that. So anyway, the thing in this article too, I love this article because it basically, you know, we're going to kind of talk about some of the things it recommends for going after your rugs, for looking at your rugs and seeing what they're doing, because they're basically saying that they suspect that these 4 states are definitely cheating, saying they're based on therapy mounts within 10 minutes of the minimum threshold. So Texas, Arkansas, Louisiana, Mississippi and Indiana. And 3 of them, Texas, Mississippi, and Indiana, are using the highest range. So they're basically pointing at those 4 and saying, hey, we're really watching. Okay, and they're not the only ones. And then let's see who's saying it'll all come down to documentation. Yes, of course. Whether the extra care is medically appropriate and necessary. Yes, absolutely. And here is the article identified 4 steps that you can do, and then there's a couple more things it talks about. And so I wanted to mention those here. Here are 4 steps. You know, is to build simple checks into your compliance programs to make sure that you have medical necessity for the individualized level of intensity. You want to review your policies and procedures of how those are set up on admission. Document the clinical factors used to set your RUG level, and document the beneficiary's response to and the benefits from the the treatments that support the need for what you were doing. So it's really basically the same thing as what we've been talking about for inpatient for 2 years now. Make sure the medical necessity there and that you're explaining your thinking. Again, I go back to Dr. Hirsch's idea, think and ink. So you've got to put all that in there, and it's the same stuff that we're looking at on the inpatient side. Now, the thing that was interesting to me was that nursing staff's Medicare documentation is now going to be, that becomes really important for this. It's got to support the need for the rehab that's being done, and it needs to record the patient's response to the therapy program. So you can't just say you did it and be done with it and claim 720. You still got to document what happened. So again, painting the picture and saying, you got to talk about the outcome. You can't just say you did it.
That's a true challenge with our EHRs. I know they're talking about doing a universal, quote, standard for interoperability. Does that put us any closer? I'm not real sure about that, but it's really a challenge to be able to really show what's going on with the patients because of the limitations within your electronic record.
And here is, Dr. Hirsch is saying, wait a minute, nurses don't do therapy. Why are they documenting it? I don't know if they're documenting the therapy. What I interpret this to be is that their documentation needs to be of the sort that supports that there was a need for this, and that
exactly.
and how the resident responded to it.
Exactly, and the nurse documentation, and that's a good point, Dr. Hirsch, but the nurse documentation can support what has happened in the therapy. So how has what has happened in therapy impacted the patient when it comes to the nursing service? You know, Are they reaching for their cup now? Are they able to hold the pill in their hand? You know, patient took the pill, they gave, and we don't document that way. And that it's not going to be, the support isn't going to be there all the time, but that's a very good point, Dr. Hirsch.
Yeah, and him saying these comments in the chat box, things like patient walked to dinner, yesterday they rolled themselves in a wheelchair to dinner, those kind of things I do think are important, and that's what they're looking for. If that's not in there and there's just, there's nothing, well then, at least that's a comment about what's going on and how the patient is responding. And then there's the last one, ultra-high therapy services are appropriate for many Medicare beneficiaries. So, but you've got to be able to show that. And so you've got to document it. You've got to document it. Same as many things. The payers are looking for this because they can deny if you don't have that. So just put it in the record, make sure it gets in there.
And if you follow that link, I think it's on one of the beginning slides, the CMS link that has a memo or something, takes you out to the CMS page, and on that page you're going to see a list of files. And if you click on the one that says, I think it says RUG aggregate data, that one actually shows you the RUG category, and it shows you the number of days that's associated with that category, and it breaks it up into the visits, whether they're low, medium, high, ultra high, and you can see the volumes associated with that. So, it just pops right at you that, something's different here. So you might want to just take a look at that if you want to, just for curiosity, see what's in their face. It does have some facility. Yeah, it does have some facility data, Stephanie. I clicked on that one, just took a quick look. I saw some address detail, but I didn't really look to the left to see specifically the facilities, but I did see some details there associated with an address. I don't know what that actually gives you, but there is something out there similar to that. So, yeah, interesting to see.
Yeah.
And what also I find interesting, Ernie, and I'm just going to mention this, is that we've talked about on this show the chronic condition data warehouse that CMS has now. And they pulled all this data from the chronic condition data warehouse. So that shows how aggressively CMS is trying to do more drill downs. And they're trying to use one source to pull multiple areas of data from. And that chronic condition database is very, very robust. I use it often when I'm looking for statistical things related to specific diagnoses.
Yeah. Okay. Well, great. So anyway, I encourage everybody to go get the original article, go look at it, read the whole article. It's on a link on each of those slides in my deck. So you can download that easily. I'm trying to make it so that people can download the deck a lot easier. I used to include a lot of handouts in there, and it made zip files, and I think a lot of people had trouble with that, so I've stopped doing that. I post a lot of this stuff then on the Aorta forum instead, because it's easier for you to go get it. But anyway, so this article, you can go straight to the link. It'll take you right to the article in McKnight's. Okay, let's move on to now this other topic, which is about the OIG basically going forward with, they signaled earlier in the year in their new work plan that they were going to focus on other things besides level of care. So basically, Dr. Larry Field posted on, it was a long discussion on the RAC Relief Group this week, and so I pulled up some of that stuff. This is something, and Dr. Field, please, and if you're on the phone, Dr. Field, let me know. I'd be happy to have you talk about this. But he pointed to this report. I didn't have the link to it directly, so I did post it on the eOrder forum. But you can go directly to it by clicking on that download link and get that report and look at it. And so basically, it was showing several things besides inpatient level of care that they were now focusing on. And basically, Dr. Field is saying, so hospital inpatient observation billing status is no longer considered at risk. Well, I don't know if it's no longer at risk completely, but certainly at risk, but they're starting to look at other things. And you can see that in here. Okay, so here's Dr. Field writes in the chat box, CMS proposed rule, March 1, 2016, revoke a physician's or eligible professional's Medicare enrollment if a pattern or practice of ordering and certifying Part A or Part B services, etc., if you fail to meet requirements. Yeah. Okay. So your enrollment in Medicare could be revoked if they find a pattern, which I guess that's kind of always been out there, but they're kind of reminding everybody. Right. But look at all these different things they're saying here. This is not a small list. Stephanie, it was probably published in the Federal Register, but as I say, or Dr. Fields, maybe you remember where it was published. You pointed to it on RAC Relief, but I didn't have a link to it, so that's why I posted it. If you click on that link, it takes you to the order form. You can download it there. I don't know where it was published. I assume it was published in the Federal Register. So anyway, but look at that list. I mean, that's not a small list. Things like outpatient claims greater than 25,000. Wow. Outpatient claims of modifier 59. Outpatient claims billed with evaluation and management services. Oh yeah, probably not many of those. So lots of things they're looking at. Now, this prompted a lot of comment by several people on RAC Relief, so I'm trying to get my pointer back so I can go to the next slide. And here's a comment that was made then by Dr. Hirsch. They also noted that the hospital was cited for improper E&M coding by its employed physicians. And that looks like it's kind of new. I don't know how new it is. I think they've been looking at E&M for a long time. Maybe they're just focusing on it more now. But yeah, and there is an issue. There's a risk associated with hospitals are buying up these physician practices right and left, and there's a certain risk for it now because the hospital now becomes liable for the E&M coding done by these independent doctors. So that's a risk, and there's a tool that we're going to show you in a few weeks that can probably help you look up that kind of risk before you buy that physician practice or group of physicians. And we will get to that in a few weeks. And it actually works pretty well because somebody saved $1 million after they evaluated the risk using this tool, and then they were able to take $1 million off of the purchase of the practice. So it's kind of a valuable thing to do. Go be sure what you're getting into. Go ahead, Sharon.
Yeah, and what I see a lot with E&M services, I just was involved in doing a OIG review with a colleague of mine, Mary Gregory, for a hospital related to E&M levels. where they were having to pay back hundreds of thousands of dollars for an inappropriate E&M assignment. And lots of times what you see with that is it's not age-specific or patient-specific documentation. Sometimes just in generally, you might see that you have a 2-month-old baby that says gait is normal. Well, a 2-month-old baby doesn't have a gait necessarily. They're not walking. Are we talking about how their hips are aligned, and does that appear normal? Because our electronic health record is driving us to customize templates that we are just clicking through. So there's not information or documentation that is patient-specific and age-specific related to the patient. So therefore, you don't necessarily have your E&M support that needs to be there to support the level. Sometimes you don't see documentation of time very clearly. I think lots of EHRs are trying to include that component within the documentation, but you don't always see that, and then you don't always necessarily have good support with using that. So E&M, it continues to be a focus and will continue to be a focus, and because of the way our information is being templated out and we have copy and paste, providers are probably going to run into some trouble with that.
Yeah. Oh, and Dr. Hirsch, leave it to Dr. Hirsch to know where to go find something. He posted in the chat box a link to that report. It is on, I can't make out, okay, it's on the OIG website. Thank you, Dr. Hirsch. So then there was another comment. This was our friend Glenn Krause commented about this, and, starts talking about this idea of gold sheet coding. The idea that, I guess it's, Sharon, maybe I ought to let you talk about that. I'm not sure what Glenn was referring, but it sounds to me like, they do things a certain way, and that's just how they do it, and it hasn't been challenged before. And then there's also this idea that the role of coding has been downgraded to production coding.
Productivity and coding is definitely always a factor because you have your DNFB, your discharge and final bill, that you have to meet, on a weekly basis. You have to code so many charts to ensure that you're going to be able to capture those dollars, put them in the bank so they can grow some interest. So there's always pressure for that. And coders struggle with quality versus quantity, and right now with 10 and the level of learning that we're still in, because, think about it. We have all had some great I-10 training. We all know the basics, but and once again, I'm going to mention Mary. As Mary Gregory and I say, there are levels to ICD-10 learning. We had the introductory stage, and then you got to get into the application stage. And the application is where we're taking what we learn and applying that and using that in a real chart environment. And that's still taking a lot of learning because guess what? We're going to try to get to the mastery stage. And that's the final stage where we have all those key things. So quality, basically with all these other things that we just went over, Ernie, is just so important still, but we still want to push to get those charts out. It's just hard to balance. It really is.
Yeah. Okay, and Dr. Hirsch is going to embarrass me because I didn't overlook the $49,000 finding. I don't know what it means. So remember, I'm a layman. I'm not clinical. I don't know if that's an appropriate kind of amount of money. It surprises the heck out of me. You're talking about 2 ounces of liquid, and they get the bill $49,000. Okay, so Sharon, do you understand that? Dr. Hirsch says
I do. Yeah, she didn't document that the chemotherapy was actually given. So therefore, how can you charge for something that's not given? And I would say they actually got it easy. This is a chemotherapy drug worth $49,000, and lots of those are $100,000. So they actually got that one kind of easy. But that's what's happened. That has to be documented. Your start time and your end time and your route and all that has to be clear within your documentation and how much is given, and then also your, if you have any wastage or not. So there's just many components associated with that. And if you miss one piece of that and your chart gets reviewed, your money's going to be taken back.
$49,000 for 2 ounces of liquid?
Yeah.
What's in it?
This is a chemo.
They're crying out loud.
It's a chemo drug,
chemo.
Ernie. Chemo drugs are vastly expensive. I think Neulasta is 5 milligrams. I think a charge for that is roughly about $100,000, as I recall. I haven't looked at that charge in a while, but it is pretty expensive.
Wow. I had no idea they were that expensive. That's
okay.
Yeah. Well, being a layman again, I didn't know they were that much. Wow. This drug was for melanoma. Okay. Well, that's a pretty expensive mistake. And I don't know how you fight that. I guess you can. There are ways to fight that, I'm sure. And I'm sure Jessica and Abby could tell us. They'd be happy to argue something about that.
Well, I mean,
that's
she
what they
didn't
do.
document the administration. That would be a tough one to find, because how are you going to prove you actually gave the drug?
Yeah.
I don't know.
Yeah.
I'd have to see the chart.
Well, if they got better, I would think that would mean something happened. So, okay, so let me go back to, that was Glenn's comment. And here's Dr. Robert Wagner. He's a guy I talk to once in a while, and he's saying that, yes, absolutely, he totally agrees with everything that was said before, because what's happened is the focus has shifted from level of care to other compliance issues. Okay, so very much what we've been talking about, for the last 3-4 months. Things are changing. Level of care is not the focus anymore. Most of you on the call are probably good at handling those kind of things or know what to do. There's probably a few of you there are some new people on rack relief, I know. We've seen posts by some people who are brand new physician advisors, but it's moving out. It's moving away from care.
And I think, a lot of this has to do with awareness shift, Ernie. I've been following the OIG stuff, 20-some years now, I guess. They've always looked at a lot of this stuff. It might not be the quantity and the amount that they're looking at it now, but I think we have heightened awareness. I think because we have great physician advisors out there now, because we have a team and a group of folks that are focused on audits and denials. We have an audit team and a denial team in many hospitals now, or we have a person that has been designated to do that. In the past, this fell under compliance, really, and the compliance did their quarterly audits, and they'd come talk to us a little bit about what the results were. The OIG stuff, they kept it undercover. It's in their binder, in their office. They're not sharing that because they don't want anybody out there in the public to know they're in the middle of an OIG audit. However, they're going on right now every day. Now, whether you get a CIA, a corporate integrity agreement behind that or not is a different story, but they're happening. So I don't think it's necessarily that the focus has shifted out there in the world with CMS and OIG. I think our knowledge of it and our ability to identify that this is happening in our hospital and our actions to do something about it is what's really increasing. Because I've done this stuff a long time. It's not really new. We've been looking at Modifier 59 for years and years and years. But they've realized that it's more of a problem and that they needed to do something about it, so they created 4 more modifiers. Now, are we as a facility doing something about that? Do we know that these are put out there to get us in trouble? And did we put an action into place to make sure we're not using that appropriately? Some might have, some might not. So I think it's just our awareness, and we just really have to stay on top of this stuff.
There was one comment I wanted to make here because Dr. Wagner pointed to this article by Frank Cohen in Rack Monitor from March. and I went and looked at it because Frank's a friend of mine, and I like Frank's stuff that he writes and what he talks about. And he was saying that E&M error rates are being reported at nearly 40%. Well, what Frank had to say about that was very interesting. Now, think about this. Here's the story. Frank did he did his own survey. He got 100 coders, and he basically put them in a room. I don't know how he did that, but he didn't try and pick, all experienced or all inexperienced or anything. He just took 100 coders, put them in a room, and gave them I think he gave them 4 or 5 records to look at and to code, and they were to code them as either a level. They were meant to be coded as level 3, 4, or 5. And he had them each individually do it and look at it. Well, if you looked at he's a statistician, so he looked at it. He looked at the statistics of the differences. When there was only a 1-level difference between what these 100 coders said, that was 40% of the time. A 2-level difference, that was only like 7 or 8% of the time was there a disagreement on that, like between a 3 and a 5. But between a 3 and a 4, between a 4 and a 5, there was a 40% difference in agreement. Now, what does that tell you? To me, it says that you can probably count on that kind of an error rate at one level difference.
E&M level is not an exact science. There is flexibility in the E&M level assignment. That's why facilities, they have to stay on top of the education for that and looking at that. But E&M assignment is difficult, and you can have many different responses off one person. Coding in general can be difficult.
And even if you put 3 coders in the room and ask them to do that, you may get 4 opinions. Because sometimes how do you know which one to do? My point is this. Number one, it's a subjective decision. There is no way, and I know I created tools in Excel and things like that, or even on paper, that are for determining E&M coding, but it still comes down to there's a portion of it that absolutely is subjective, especially when you get to medical decision making. It's absolutely subjective. Now, there are some things that you can check off certain boxes, and it will say you can do a level 5, but you better have the medical necessity in the documentation that says that it is a level 5, and it's worthy of a level 5. You don't get to just check boxes. You're going to have to prove it. Now, that seems like a lot for an E&M code and for the amount of money you're getting, and that's part of my point. But the main point, and that Frank makes, is that, look, if you're getting hit for a 1-level difference, fight it, because it is totally subjective, and you can bring out reports and things that will say, look, this is you're going to get a 40% difference depending upon who you talk to. So why am I being penalized for that? Am I wrong? 40% of the people who would look at it would say I'm right. So and to me, that's the same kind of an argument that I think should be made back at level of care. It's a subjective decision. What's the error rate? I think in that case you're talking about it could be a huge difference, even more than 40%, because it's a subjective decision. I think that's a great argument, and we'll talk about that more in the future. But that was something that struck me from looking at this. So I'm going to go forward here because I've said enough about it, and we got to get to Sharon's piece about how she did those denials. Anyway. This was this was Sharon, this was her comment then about it finally on that. There's been a change, a modifier 59. That's going to be increased scrutiny, and we already saw that in this report. Now Sharon's been looking at this and talking about this for more than 2 years, because she wrote an article back in 2013. She did a webinar about it, and you can get if you use the links on this slide, you can go find the article. You can go find the PDF of the slides from her webinar there. And then what I asked her to do, I said, okay, so let's talk about some examples. And so she came up with 2 examples she gave me that we can talk about. Well, how do you deal with these denials then? How do you get them overturned? And so then she gave me 2 of them. and they come from. Well, maybe I should shut up now and let you talk, Sharon. These were basically information that came from your webinar. So I'll let you talk now.
Yeah. Just to start off, when coders code a chart, they want to code based off physician documentation, because really that's what the guidance tells us. It has to be documented to be able to code it. And at times there is clinical that comes into play that needs to support the documentation. And as coders, we struggle with that. We struggle with a diagnosis being in the chart and then have to worry about, is that diagnosis clinically supported? That's outside of my realm as a coder, is kind of the thinking. So I just want to code the words that are documented. And so I think the RAC started, and they started determining that, look, we have lots of diagnoses here that aren't clinically validated. And I'm going to use sepsis to start it off with. We have a lot of sepsis documentation because guess what? We have all these great CDI programs, and we're really educating our physicians on how to document, except sometimes we leave out the other important pieces of that. And so we have heightened documentation for a particular diagnosis. So CMS says, we're going to come out and I'm sure it was probably through recommendation from RACs, with clinical validation. So when I saw clinical validation, immediately I'm like, oh my gosh, this is horrible that they're going to look at this and we're going to get denied for this. That just kind of panicked me right away, and I knew that would be a concern, only because that's not the coding mindset. We don't want to worry about the clinical piece of it. So this is a little snapshot here of the statement of work and how CMS says that. So not only did CMS make a reference in the statement of work, they said, you know what, we got to relate this outside of that. So we're just going to make a MedLearn Matters and let everyone know that we're concerned about clinical validation, supporting your diagnosis through what you do. And they came out with this MedLearn Matters. So you could go out there and read about that. But basically it says that what you code and submit for billing needs to be not only documented, but it also needs to be clinically validated. So since that time, I've had a lot of focus with supporting hospitals with their clinical validation. The clear and dry coding stuff that's based off a coding rule, and I have a clear guideline or a clear coding clinic. Lots of facilities don't have problems with that. But the problems comes in when I have to relate clinical support with guidelines and with coding clinics. And for those facilities, that's all I do for them. I just look at their clinical validation accounts and relate that back to coding rules, as well as clinical for the patient, whether that be through explaining what a diagnosis is or showing what treatment was given for that diagnosis, whether it be drugs, x-rays, interventions, or procedures, and lay that out. So you can go to the next slide, Ernie.
Okay. As I was just thinking that. So that's the challenge.
Absolutely. How do we address that clinically? And, it's just what you were just saying a few minutes ago, Ernie. Subjective in a sense. What do you mean by this? Getting that auditor to understand a diagnosis and what was meant behind it, and relate that to the guidelines. That can be very challenging. So you have to relay it very plainly. I find myself educating auditors quite a bit, not only in just plain coding guidelines, but in a clinical condition, the relationships with one diagnosis to another, how this symptom led to that symptom, how I gave them this drug and this drug did this. So it's a lot of involvement in doing these types of denials. And luckily, we've had a lot of success being able to do that, but there's always going to be those that you don't get success with.
Yeah. I'm sorry, Samson agrees with you, my dog. That was him barking. I just had to let him out. Okay. So, all right, so let me get to the example. We have two examples, and I think we've got enough time to go through these here. So this is the first example that you gave me, the one about pneumonia. Probably pretty common one.
Yeah, and I mentioned about pneumonia. That was one of the things I kind of started off with the presentation I did on Rack Monitor, because I said, we've seen this before, and we've seen this before back in I think it was the early 90s with the pneumonia denial, where we were inappropriately assigning a diagnosis of pneumonia, and we had a huge amount of pneumonias out there where the patients didn't have pneumonia. Maybe they had bronchitis. So the OIG started focusing on it. And in those OIG reports, it states clinically these patients did not have pneumonia. So
right.
CMS really didn't come out with a, quote, guideline for that until the RAC statement of work came out, but it was a problem. So now here's an example. You're still seeing that. This is one that was related to pneumonia, and clearly the patient had pneumonia, but they were trying to take the pneumonia away. So, break down the treatment of the patient here. That's kind of what I did in the beginning. All the different places I saw that at, what the lab values were, what the drugs were that were given. And then finally, take that back to coding guidelines, because that is what you need to use for the auditor to stick to. When you're doing clinical validation, it cannot be all about just the clinical, because you also have to be able to support your coding. So I did do that by pulling in the guidelines related to that. One of my favorite ones is this one: clinically evaluated, therapeutically treated, or diagnostic procedure causing extended length of stay and increases nursing care or monitoring, and address the chart to those particular issues. How did those things happen? Here it is. My diagnosis supported because all these things happen. So you have to kind of lay it back out there to them and let them see it plainly. If there's a coding clinic related to your particular diagnosis that you can pull in that coding clinic. Offer all the support you can for that particular diagnosis. And that'll help solidify your denial. And, with Humana loves to do this. And I know Dr. Hirsch loves this because, we talk about Humana all the time. But Humana loves to do this. They love clinical validation. In fact, I would say probably 90% of the denials I see are related to clinical validation when it comes to Humana, not necessarily clear-cut coding guideline errors, clinical errors. And that's because as providers, I don't think we always want to challenge that. With a few facilities that I work with, they do the easier straight guideline stuff, send the clinical stuff, and then in many cases they have trouble responding to that. And that's why they send that stuff out, because it can take thinking across not only the clinical picture of the patient, seeing the interaction with other disease, as well as applying it to coding guidelines to be able to overturn that denial. So there are many pieces involved in that, and who has time to do that in the hospital?
Yeah. But anyway, you got that one overturned. I heard somebody saying in the chat box, in these clinical validation reviews, for the auditors are citing medical guidelines, often from just a medical book, where they want to see specific lab work, diagnostic studies, etc., that sometimes an experienced practitioner may not need to determine the diagnosis. So those things are not necessary at all times. But I guess so. The auditors are looking for that because they can. Yeah. And here's Stephanie Daniels saying, "Pay attention to your contract. What's in your contract?" I'm not sure that this kind of depth of detail is in the contract.
No, it's just going to say we'll do DRG reviews. Yeah. And what DRGs include is laid out there for you in the CMS, Medical Review Policy Manual section. Clinical validation is in there, and it's a component of the review process. You have pieces of the review process. You have the patient status piece, and then you have the DRG piece, and then you also have the disposition piece. And all those things play into a medical review. So in many cases where you get those letters back, you thought it was for DRG and it turns out they're looking at disposition. That's part of the CMS medical review process. And they lay that out in that chapter of what's components of that. Now, if you have a very specific contract that states you're going to exclude those things, that would be great. But in many cases, it's just a generic DRG review.
Yeah, and here's viewer 27 commenting that many auditors have strings of credentials, which shows they have good test-taking skills, but they may not have actual auditing experience. And others, like myself, have many years of auditing experience, but I don't have the string of credentials. But I understand all the processes. It takes time to understand them. I agree. There's a problem with that. Yeah, that's a great point.
I love that. I was just talking about that earlier this week about being a great test taker and how that can impact possibly, getting a credential or not. So I think that's a very good point. What I find, and I know most of you will agree that, most of our auditing is not up to snuff, or is this a situation where they're just stamping denials? And using clinical validation may be a way to easily stamp a denial. In some cases, there are accounts you have to dig with. Encephalopathy is the next example. That's a problematic area out there where we don't necessarily understand how to apply the code of the diagnosis or not. But beyond that, I think our reviewers or auditors out there don't understand encephalopathy. They don't understand the causes of encephalopathy and when it is appropriate to use that or not. So I educate them on what encephalopathy is, what causes encephalopathy, and then I show them, look, this patient had a toxic effect of a drug, and here it is. It tells you that she took too many of, whatever that medication was, and give it back to them and put it in their face. That here it is, this plain, and if I can back that up with a coding guideline, which I do, I'll do that. And if there's a coding clinic, I will back that up with a coding clinic. Yeah.
And here's somebody saying that they've noticed that the auditors sometimes using coding clinics to deny diagnoses, not realizing that they don't pay attention to the fact that the coding clinic is a particular scenario. It doesn't mean that's a guideline for every case of that diagnosis.
Oh, that is that is such a great point, Ernie. That's something we have to remember with coding clinics. There are some coding clinics out there that we can apply to many things and many types of cases, but there are many cases of coding clinic that are very specific, that are related to a specific issue. And we try to apply that, and it is not. So I've had to appeal that way before. I've had to include in my letter that, look, you are misinterpreting this coding clinic. Coding clinic is written specifically for cases, and this case does not apply to the coding clinic you are referencing. See this guideline, and just kind of give it back to them.
Right. Yeah, and so here's Sharon basically, putting forth that information and then saying, you're basically not being consistent with what's appropriate.
Exactly. So clinical validation can be a lot of work sometimes. It might take a lot of pieces. Not only do I sometimes have to use physician documentation, I have to use that nursing documentation. I'm using that radiology. I'm using that op note. There's something in that op note that relates to this diagnosis that I can use to substantiate it. Just a very thorough recap in very plain and easy language for the auditor to see to validate the case.
Yeah. Well, and that's another successful decision overturned. So I hope all of that is helpful to everybody. You can see that, how Sharon does this and the tips on how you can attack these. I do think, it is a scary thing. I remember first time Sharon described to me clinical validation coding, and I had the same reaction. Oh my goodness, that's we're talking about, it's so easy for them to deny and then just basically dare the provider to come back and do anything about it? Do you just eat it, or are you going to go ahead and fight it? And how much is it worth? And how much can you afford to spend fighting it? So, it's a terrible situation.
Yeah, we've set ourselves up with CDI programs to be for clinical validation exposure, where we haven't completed the process. We're not staying on top of the process, and we don't have that correct type of engagement with the physician and the understanding of the impact. So we've set ourselves up kind of for a lot of these, and we have to stay on top of them. I think it's many more to come. Yeah,
I don't think it's going to get better before it gets worse. Okay, well, that's our show for today, everyone. Thanks very much for being with us and sticking with us on this. I hope that was very useful for you. I thought it was very interesting this week. We are going to continue working on, what we call Operation Rethink, talking about outpatient and other things besides inpatient level of care. We are going to talk later in the month about, tools that are out there that you can try to see your data like CMS does and why you may want to do that. You can do it with big packages. You can do it with small packages. But there are, ways to do that without just using spreadsheets. And then I am still working on these other shows to come up with. And I do know that I'm going to have Dea Kaskiza on the show here in a couple of weeks, and we're going to be talking about managed care frustrations and anguish. So look forward to that. I will be able to tell you about that soon. And that's all we have for this week. So we'll be back live next Friday, March 18th. Don't know what we're going to do the show on yet, so watch for my announcements. Thanks to everybody for participating today. Special thanks to everybody in the chat box. This was very good stuff. And yeah, I see somebody saying that's great. They've had woes with encephalopathy denial. So great stuff. Okay. Of course, thanks to Sharon. You're such. Sharon knows so much, and I keep trying to convince her that she knows probably more than just about anybody I know in the industry. And I'm not saying that to criticize anybody. I'm just saying that Sharon always wows me. It's very hard to stump her. So anyway, of course, we also want to thank our sponsors, Health Law Partners, MedLinks Cost Containment, Aerolib Healthcare Solutions, Recovery Analytics, and the CCMA, whose contributions continue to make these broadcasts possible. So everybody watch for my emails about next week's show. Share the links to our show with your colleagues and friends. And the last thing I want to do is share my favorite picture of the week. This is how I feel sometimes, until you have the courage to lose sight of the shore, you won't know the terror of being lost forever at sea. So the trick is, don't exactly lose sight of shore for very long, okay? Anyway, thanks, everyone. That's all we've got. We'll see you next time when it's finally Friday. Have a great weekend. Bye-bye.